add as we go through the slides. The title of what we were supposed to talk about is Study 101. Study Design 101. Look at that. Look at that face. He was like, ugh, I wouldn't show up for that talk. So I changed it. I changed it to the magnificent 7 questions for study design. And I'm going to lay out 7 questions that literally, when you're trying to first begin a study, you're thinking about sitting down and designing it. These are the 7 questions I think you need to begin with. I'm going to talk to you about the fact that I've listed them in a specific order. Do you have to follow that order, David? No, not in the first 5. But you can never move the last 2 forward. They have to remain as the last 2. You cannot move those forward. Okay? The other thing you need to understand is I'll email you these slides, I'll even give you a sheet that has these questions on it so that you can work with this when you're trying to design something. But understand, I also use these questions when I'm at NIH study section. These are the things when I'm brought in to evaluate the design of a study or a grant. These are the first 7 things I try to look at and diagnose. And notice I said diagnose. Okay? So, with that, we're going to dive in. So, please understand something. I believe Dustin agrees with this. I don't actually enjoy lecturing at all. I actually would much rather have a discussion. As we go, you can stop me mid-sentence. You can ask any question, and at time, again, I want you to flesh this out. We have to have a discussion. These are the foundational. If you were going to come into a bird clinic or you arranged an office hour to be able to start fleshing out a design, it would be good to have thought about at least the first 5. At least the first 5 questions. So this is what you should anticipate the methodologist asking you. It's okay to come on if you don't have all the answers. That's always fine. The mistake that is often made, there are 2 mistakes when we're trying to design things, and it's team science. There are only 2 mistakes. 1, waiting too long. Waiting too long to get to us. The earlier, the better. The second mistake is as you're bringing it across the finish line, or as I like to use my football analogies, bringing it across the goal line, changing the answer to one of the first 5 questions. That's equivalent to fumbling the ball. Because if you make last-minute changes, you're going to have a cascade effect that's going to throw it off. There are actually 7 questions that are often asked in review groups. They're simple questions, but if the answers are inconsistent, if I'm reviewing the grant and I see inconsistencies, do you know what I think? Or if I see a proposal for a pilot or anything, keep in mind, these questions apply to every level of design. If I see inconsistencies, what I see, I either conclude you rushed, or you didn't think it through, or both. It has to be one of those. So, here are the 7.
I got you.
Oh, you already moved ahead. Also, please understand, as we go through this, I actually cheated. You'll see sometimes one question actually has kind of 2 sides to it. If you think, and Dustin should add to this, if there are other key questions, you think to yourself, well, no, shouldn't we ask this question also? And when should we ask that question? Throw it out. Throw it out. This is a presentation that I'll be very honest. One of the reasons I was a little late. I have probably 5 canned presentations, okay, that I've been doing for the CCTS, rotating them for 5 years now. This is the first time this presentation is done. It was written this morning. because I felt like, and I'll tell you why. I'm struggling with an investigator, 2 investigators right now, and it's all over these 7 questions. We can't get to resolution. One of these grants is leaving October 5. I keep warning this person, maybe we should just tap the brakes and say February 5th. Maybe we should just say February 5th, but I'm not being heard. If we add a question or if we delete a question, because Dustin or somebody might say, isn't that redundant? That's fine. We just lose the title. We go back to Study Design 101, which nobody will show up to. Okay? I like the magnificent step. Would you click that? He and I are good friends. And trust me, I'm going to hear an earful after this is over. Rightfully so. Rightfully so. So, I always start with this. And again, I know I'm being recorded and I know I'm online and that's all fine. The other thing that when you're designing something, the CCTS offers panels for you. So once you've got it fleshed out, we'll form a group of experts to come in and sit down and tell you where we believe the strengths and weaknesses are, okay? One of the things that's always said, we always begin on that by a hard study of the specific aims. Okay, do you know, I'm making an assumption here, do you know what I mean by specific aims? Do you? All right. I tried to phrase it in a positive way. Should I phrase it in a negative way?
No.
No? Do we know what specific aims are? I want to take that as a no, okay, because I can read eyes. I've learned to read people's eyes throughout my career. I know when people look down and do not make eye contact, I know that is a definitive no, and you will not call on me.
It's also Friday morning.
It doesn't matter. I've been up since 3 a.m. drinking coffee. Can't you tell?
No.
Okay. Yes, sir. Your hand was up. Oh, no, I didn't show.
Yes, all of this is extraordinarily helpful. I've come here for my stacks consultation. It's spectacular. That's an endorsement similar to other people. This is very helpful when you are at the high end, submitting an R1, this and that, or grant proposal, or when you are early on in your career where you have never heard about a specific aim. That's okay.
That's okay. This is my point. You're going to see that and I'm willing to be challenged on this. I'm saying these are 7 universal questions. I don't care if you're doing an animal study. I don't care if you're doing a phase 4 clinical trial. These are the types of things I'm going to need to know. Don't worry, I will send the slides. You don't have to write all this down. I appreciate everybody taking notes. I will send the slides. I will give you this document. Specific aims are, and I've got a couple examples. Specific aims are, to me, a 1-sentence statement that can define and tell me what an experiment is trying to test. What is it trying to show? Okay? Now, understand, that can be rather ambitious. That makes certain people get into gridlock. Okay? But those are where you convince people that if you can say it in 1 sentence, clearly and concisely, that people understand and they can digest that. If you can't boil it down to that type of sentence, then maybe you're trying to do something that's too broad. And being broad is very dangerous.
This question is the whole point of Dr. Magavero's talk that we discussed a few minutes ago, which was how do you make a research hypothesis, research question to the point where it becomes specific. What was the other word? Specific and I don't remember. There's 2 words he said. Specific
Testable?
and something.
Testable?
Well, we got to that eventually, but that wasn't what he used.
Specific and succinct.
No, could be.
Okay.
I don't remember. But the point is that discussion of Dr. Mugamero's leads directly into the first half of that question. And then in the second half of Dr. Mugamero's talk, we talked about translating it into, Dr. Redden has statistical hypothesis, but we talked about actually being testable. The thing I gave you, the example I gave you was, can you actually follow people for 50 years in your pilot grant? No, you can't. So is it something that you can actually translate into a doable question?
Okay? And then I'm going to walk through each one of these questions, okay? And I am notoriously bad when I get up and I start talking, racing ahead, thinking ahead. But I want you to keep thinking about, again, is it testable? And I have a very succinct example of what I'm struggling with this specific investigator. I'll tell you that one in a minute. If you are stuck, if you're just stuck, it's okay to fall down and just say, sometimes I can dislodge the problem by saying, all right, let's just back up. Can you tell me, what are you measuring? How are you measuring it? Usually that can get the process going. Well, I'm going to measure cognition. Oh, why are you measuring cognition? Okay, well, I'm measuring cognition because we know with patients with epilepsy that they seem to have some issues with cognition and memory, even if the seizures are under control. Oh, okay. How are you going to measure it? And this is what you would expect with the dialogue with the methodologist. Okay, and that dislodges it. Then I can start asking the type of questions. Well, what are you going to do? Well, we've seen that exercise works well with elderly for cognition. We're going to try this in epilepsy. Oh, now we can see. To test the effectiveness of exercise training in a population of seizure-free individuals with epilepsy. There's some speed. Now there's that nugget. Do you see what I've done? So don't be afraid, but these are key things. Is the design retrospective or prospective? That's one of the key things to me. And I was adamant about putting this into this lecture, okay? Because I don't see Dr. Levitan, but the catch here is this. I have people who come to me and say, I don't need these questions. This is a retrospective study. Huh? Huh? Where did that belief come from? I don't understand that. So I want to talk about why, if it's retrospective, maybe you need these questions more. All right? Is the design cross-sectional or longitudinal? Now you're getting into statistical speak. Don't worry about that. We'll get there. Okay? How many groups? Simple question. How many groups are you going to have? But sometimes that's hard to define. That's why we can sit down with you. Now, this is where people start to sweat. What is a clinically relevant effect size? I don't even know what you mean by that, David. I mean, that's gibberish to me, David. And how does this impact sample size? I'm not joking. I've said this 1,000 times, but it's not a joke. I walk all over this campus. You'll see me all around. When people stop me on the street, they're not saying, hi, Dave, how's your day going? They're usually stopping me to say, what sample size do I need to be able to do this study I want to do, David? And they don't understand, I cannot ask or come anywhere near the answering that question until we talk about the first 5. That's why they're listed this way. It's once we get through these 5, then together we start hammering this piece out. But people are always so obsessed about how many people do I need? How many people do I need? How do I get to statistical power? That they rush to this. Please trust me. The best place to start, I should have put, how are you measuring things first? And then that will help you flow in the specific areas.
But one thing to point out here, and I know you're going to come back to it in this section, is that we understand, as the methodologist, as you put it, we understand that sample size is very important to you for one major reason: budget.
Yeah.
when you're planning a grant, your budget is due and needs to be worked out fairly early, and even before maybe your significant section or your innovation is worked out, you have to work through your budget. So we understand that it might come earlier than what you think, or what we are suggesting, but that doesn't mean you shouldn't have already worked through some of these questions. Now, if you have to iterate, that's okay.
Fine.
But
That's fine.
we know why you need it.
We do.
We do. We understand why you need it. We appreciate it. But we have a cart and we have a horse. And the horse is the question, the cart's the sample size.
That's exactly right. There's no better way to say it than exactly that. That's exactly the situation. I cannot deal with the cart until I know what horse is going to be pulling it. Okay? So, to echo exactly what Dustin just said, that's the absolute truth. We recognize how important it is and that we've got to get the budget settled. Have plenty of discussions about budget. As urgent as that is, that means these first 5 should be answered as soon as possible. Then the better you can answer them, the more solid that budget is going to be. Okay? Then I know what I'm willing to bet. I know what Dustin's already thinking, and we'll see if he can predict when I get to what I have put as a comment on my 7th slide, on the slide for question 7. But what should the analytic approach be? I'm not asking you to write an analysis section. I'm not. I would like to come beside you as your collaborator after helping work through these specific aims, all of this stuff. Then we as a team sit down. You've educated me about your science. I help write that. We help write, teams help write. I have people review mine. Here's a stats section that goes with this set of answers. It's imperative that things line up. You'll hear it often said, there's a bait and switch. We've said we're doing this with regard to power. And then we look at the analysis section and they don't align. That's bad news. That means we don't have a really solid study design. We don't have it yet. When I see that misalignment, I'll call it out. Go ahead, thank you. Okay, so here I want to go back to this one because I really want Dustin's input on this about testable hypotheses. I almost use the word testable, but I try to avoid terms that actually have specific meanings to statisticians. And my children always say, hey, I just had a random thought. I actually say it's probably not random. Because random means a specific thing to me. And they get frustrated with it.
I don't know about your kids, but my son does have random
No,
thoughts.
my daughters do not have random thoughts. They don't. They're trying to set me up. Do they translate into statistical hypotheses or testable hypotheses? Here's the example I gave you. Test the effect of a 6-week exercise program on the cognition of geriatric patients. I've changed it to geriatric. Because literally earlier this week, I met with someone about designing this type of study for epilepsy. Okay? However, it's kind of complicated because they're doing a lot of imaging and all this other stuff that we've got to work through. But nevertheless, there's going to be a control group. There's going to be a group that's randomized to exercise. We've got a pretty fleshed out idea. However, another one I'm working with this week that I struggle with is demonstrate, should have been that, the bacteria X is present in the biofilm of bacterial vaginosis. I'm not certain that's a testable hypothesis. I'm not certain, and I'll tell you, literally, this is what went down on Tuesday. Okay, so explain to me again. How are you going to do this? Okay, we're going to have a picture of the slide. We're going to dye the slide, and if it grows green, that bacteria X is there. Okay. Are you going to quantify the illumination? No. The evidence is the picture. Okay. Then there's no analysis plan. But I need an analysis plan. Let me ask you again, are you going to quantify the image? No, the image is the result. I need an analysis plan. No, you don't. And this has been ping-ponging back and forth.
Is this Christina?
Would you hush? Don't run.
I'm trying to guess who all these people are.
No. Hush up.
But I think.
But do you see my point?
Yeah.
And how would you handle it?
I don't know, because it determines on the investigator and it determines the question. My experience has been having aims, specific aims that are qualitative in nature. And when you have qualitative questions, which this is really somewhat of a qualitative question, you don't have statistical analyses like we described. You would go and talk to qualitative people, and they would give you the ways that you would work with qualitative data and tell you need to look at this many biofilms or interview this many people in your focus groups, those kinds of things. That doesn't have what we would call a statistical analysis plan. Likewise, the way I've seen it a lot lately is a qualitative aim. The second aim is adapting some intervention for your population. There's some intervention that exists, some medicine, some drug, something, and you want to adapt it to your population based off that first aim of your qualitative data. Again, there's no analysis on adapting an intervention. So you won't need to have us or someone else give you a read-through of that aim. The third aim, however, is typically the pilot study. That is where you would want us to come in and give you our expertise, our opinions, our read-through, whatever you want to term it. And it is hard for some people to realize you don't have to have a power and sample size and analysis plan for every aim in your grant.
Would you repeat that? Would you repeat that, please? Repeat it one more time, please.
It is hard to believe that you don't need an analysis plan and power and sample size for every aim in your grant or your paper.
But you have to trust us on this. There are times that it's not needed. Here's the teaching example I've given 1,000 times, and I'm being sincere. So with the Manhattan Project, when the atomic bomb exploded, there were plenty of physicists around, a lot of military people, and possibly one Soviet spy. But I guarantee you they did not have a statistician present to measure it. Because when the bomb went off, it was sufficient proof in itself. Okay? If you're gonna make the bacteria glow, and you're saying nobody else has shown that the bacteria is there, and you're not quantifying it, you don't need me. It's okay.
You will have to have replicates.
I understand that, and I've talked to her about that. But give me 5 pictures of glowing bacteria. But I don't need to talk about how I'm going to build a regression model on it because it's a bold-faced lie. And it gets kicked out. Okay?
Well, what it'll do is if you're sending this to an NIH study section or a DOD grant review.
Or you get it presented at journal at the grand rounds. Go ahead. Even if you don't go to study section, if you try to present that at grand rounds.
True. But if you do go to a grant review and the statistician reads it, they're going to start laughing and your score is going to plummet.
Yeah.
Well, actually, NIH rates go up. But, I'm used to DOD and one is bad. But
be nice to be consistent.
So, and that's the last thing you want to do is because the statistician isn't going to get your grant funded. A statistician reviewing your grant or looking at your paper, I'm not going to be able to get your grant funded, but I can get it hurt.
That's exactly right. And I will say this to you, and I've said this 1,000 times, and I mean this. All I can do is move you either closer to the finish line, to getting over the line, or I could hurt you. But I have never in 24 years ever had a grant come back or a paper come back that said, man, this research hypothesis is crummy, but that's the best analysis plan I've ever seen, so we're going to fund it. It doesn't happen. They don't publish papers because of, wow, that was a crummy hypothesis, but look at how great that analysis plan is. It doesn't work. So we have to work together on this. But I will tell you this, I have had papers questionable on the bubble of getting published. Then somebody's come in for a clinic, and I said, don't worry, we'll take care of this. And they'll say, well, how are you going to do it? I said, all you need is one graph. One graph will tell them everything. And once they see that graph, it's done. So you need to be aware. We can move quickly in one direction, but it's got to be with a very good hypothesis. Okay? All right. Those were my two examples, and along with the Manhattan Project. Can we go ahead?
Yeah.
Oh,
questions,
oh, yes.
comments. This is supposed to be a discourse as much as a lecture. So,
Yeah, so well, we're talking. Look, there was a hand. I saw a hand. No, I didn't see a hand.
yeah, there's a hand.
Okay, go ahead.
But I'm giving an opportunity for others to open their mouth. So just quick thing. Sorry I had to step out. Love the analogy of the horse and the car, especially if you're in New Orleans. Get to a nice horse with a nice car. As before you do that though, pull your phone and get the Google Maps with your mentor. So, because in that way, someone needs to direct the horse where the car and you should go. So, and that probably should go even before they even talk to you guys. Otherwise, that may not be the best use of you.
Or the other thing that I've had great success with is there's a pre-meeting between mentor and fellow, and then there is a follow-up meeting where I told you about the office hours here, but we also travel. And we are more than happy to walk over and meet jointly with mentor and fellow together to flesh out these types of things. All right? Anything to add?
So I have a question. I read a grant proposal. It says that first, a specific aim. First is implement a program, The second one is test the difference in participation between African American and the whites. So how about the first, the specific aims?
It would depend on what you're implementing. I don't want to say no without knowing more details, because that gets us in trouble, because then somebody here is going to hear that and be like, oh, I'm implementing something, I don't need to have that discussion, when that might not be the case. Because it could be that you're going to implement something, but later down you do want to test if the rates of African American uptake and white uptake are different. Well, that means that when you implemented something, you've got to make sure you have enough people to do that.
Right.
So we would need to have some discussion about sample size analysis for that first aim to make sure you can do the subsequent aims. So do you need it for this one?
Don't know.
Don't know. Would you need it later? Yes, and that affects the whole grant. That's why bringing somebody in for one aim sometimes is a bad idea, because your aims should be correlated. There should be some progression through them, some relationship between them. So you don't want to try to do an aim all by itself, because if you have like two aims that are related and then a third aim that comes out of nowhere, you're going to get hurt.
Yeah.
Okay,
So the minute you said implement, my ears went up, mainly because I knew there would be a possibility that that aim might not need an analysis plan. However, I would have to sit with you. But when I hear the word implement, that's one of those words that makes me immediately ask, is this going to be a testable situation? Someone says test the difference, then I know we're probably going into statistical hypotheses. Okay?
Okay, thank you.
Huh?
Thank you.
Other questions? All right, let's keep going, because I usually try to give you all at least 15 minutes back on a Friday morning.
And this is the next time. We can go into two if you want.
Okay, no, this is fine. I didn't realize you moved it ahead. I did have two slides here. If you're struggling with your aims, it's okay to meet with the methodologists. It's not like I can't talk to them until. No, that's not it at all. We can help you think through it. The other thing to remember, flipping the order sometimes will help you greatly. If you're just struggling, back up and say, what would I like to measure?
Because there are some projects, projects in which what you have is a data set. And you have some questions that you really want to answer, but I don't really know how to get at the questions because I'm limited by this data set. Like, add health. You're very limited in what data are available there. So you can't just have a broad, wide open, specific aim that asks questions that aren't able to be answered in your situation. So moving them in a certain order, it makes absolute perfect sense. Just understand that before we can give you question 6 sample size, we need to work through the first 5.
Right, question 6 and question
Or
7.
I'm going to tell you infinity.
Well, question 6, questions, I'm just saying, I don't know. Question 6 or question 7. Question 6 and question 7 have to hold. They have to hold very. All right, going ahead. So now I'm just going to get down to it. Are outcomes clearly defined? That's the other thing that I'm struggling with. Is, I hate to say it, but sometimes I really hate squishy outcomes. And I don't mean squishy in the sense of, well, this is, how do you feel today? No, I can analyze that. I can still analyze how do you feel today. Squishy means you're not certain. You're not confident in what you're putting down as your outcome. You haven't made up your mind. That puts me in a bad spot, okay? Not that I'm going to be angry with you, but I am going to keep pushing you toward, you've got to have this down.
Does anybody do physical exercise, physical activity? Anybody research that?
Yes, I exercise daily. Go ahead.
So, what outcome is best? Weight change, BMI change, waist circumference change, waist-hip ratio change, or VO2 max? Which is the best outcome?
It depends.
Yes, exactly. But what we have happen to us often is somebody will say, we're going to measure all of these things and we're going to see if people improve. Well, you can improve on one, not the other. Like I can lose weight, but my BMI not change because I added muscle mass, right? So I don't know how you change your hip weight ratio without changing those stuff. But anyway, that's kind of what it is you come in and you have all these potential outcomes, but there's not one that really is this is what I really want to measure.
And there is a follow-up slide of this one also, but honestly, you need to really stop and think, is it a yes-no? Because if it's a yes-no, that's going to lead us in a specific direction. Is it a rating? Like I said, something on the Likert scale. Satisfaction. I have a very large clinical trial, believe it or not, of 1,100 people that at the end of the day, what am I going to be actually analyzing? How satisfied were you? Is how knowledgeable. It's just satisfaction. It's a very large trial. If you're using, and then bottom line, or is it a quantitative measurement? Is it something that you can give me units on? If you give me something that has units on it, that tells me something else and leads us into another range. You don't have to, I thought about putting up a nice flow chart for you and all of that, but I thought they would run out of here. They'd never talk to me again. You don't have to find your way through the flow chart. We're here to help with all of that. But these are the pieces that we need to get through that flow chart.
I may have missed it, but
You probably did.
why is the rating considered quantitative?
Because the ratings are simply this. All right, so let me ask you something. So I bought my wife a car a few weeks ago, and me being the type of guy, and she being really, she worries about the daughters a lot, so she wanted a 5-star safety rating. I asked them, what's the price for 4-star? I'm willing to give up a star and take the risk of a broken leg. I'm just joking. She would have killed me. But what's the difference between 5 stars and 4 stars? Do you know?
Yeah, I had nothing. I mean,
And at the end of this, I will ask you to please fill out the survey we sent, and we will talk about on a scale of 1 to 5. How useful was this presentation to you? The bottom line, one person may say 5, The next person may say 4, but the distance is not 1 because I don't know what you're anchoring on. So there's really not distance there. That's why when I say quantitative, I can start talking about doing distances and really having an interpretation to it.
There are a lot of statistics I dislike. I mean,
There's a lot of statisticians he dislikes. Go ahead.
Likert scales, these ratings that people use all the time, agree, strongly disagree with it, I hate them. They are, to me, almost useless. But do people use them? You bet they do. Do people take the mean of them?
Yes.
And tell me, oh, look, the mean in this group is 3 and the mean in that group is 2. Useless. I'm a professor here at UAB. Guess what number I get from my teaching evaluation? Oh, on culture appropriation within your classroom, I got a 2 out of my 3 students who filled it out in a biostat classroom.
I think he's passionate about this.
I hate Likert scales. I hate
It's useful for Amazon though.
You could argue Amazon has so much data, everything is continuous at that point. But if you end up with 400 million data points, come talk to me. We'll figure this out. And it's mostly because people use them wrong. Because everybody thinks, oh, it's numbers 1 through 5. I can take the average. I can do a t-test between these. I can do a linear regression between them. And none of those things are appropriate. Which is why those are the cases we really want you to talk to us. Because we don't want you to think this is okay and it go to review and the journals kick it back and go, this is terrible, you wasted all of our times. Because we don't want that. We don't want that.
The other thing is if you're using like an instrument, and this is one of the things I've got to be very careful about. If you're using an instrument, something that you're going to say, well, we're measuring depression. Well, there are some very good, validated psychometric instruments to measure those types of things. You're going to want to use all that knowledge to strengthen all that literature that goes with that validated instrument to strengthen your proposal. My biggest advice to you is don't think you're going to be able to just, in addition to what I'm doing for all this, I'm going to develop my own instrument. Usually that's a kiss of death in a study. Because if you get something that's validated, that's better. Okay, it will help you in publication.
But if you were to talk to us, or a methodologist, and you said, I really want to do an instrument like such, and there's one that's validated that doesn't get at exactly what you want, but it's there. Maybe yours is shorter. Maybe yours is 5 questions, but that one's 18 questions. Then we would tell you, okay, let's ask everybody both, and we'll do all these statistical measures of association between them, kappa and all Cronbach's alpha or whatever they are. We can do all those things, and then your paper becomes even stronger because then you can say, this is the validated thing everybody uses. Mine is just as good, and will take the patients half as long.
And I did that one during the summer in one of the bird clinics. All right, go ahead. All right, is the design retrospective or prospective? Okay, listen to me. Sometimes you've already got the data. Dustin's already brought that up. It's already done. You've got it. Okay? I mean, it is what it is. Dave, here's the data set. Go! No! Can't do that. We still have to address the previous questions. All these things are related. I cannot tell you how many times I've had people come back and say, we just spent 2.5 years doing a chart review on things that aren't in the EMR, and I'm ready to answer this question. I look at it and go, you can't answer the question. You didn't design it right. This thing's hopelessly confounded. Retrospective studies are often more problematic than prospective studies. The problem with prospective studies, you got to find all these people. You got to get them enrolled. You got to consent them. You got to do, and so everybody says, oh, it's so much easier because in the retrospective, all I got to do is find the charts. Confound it. So you've got to think about.
Here is what happened at my previous institution. somebody wanted to get an estimate of cancer rates in West Virginia, and they wanted to do it by zip code. They said, okay, we're going to take West Virginia University's health systems, EMR, and we're going to pull every patient out of the EMR, and we're going to get their ones that were cancer diagnosis, and we're going to map them on the thing, and we will know the rate of cancer in West Virginia.
Bull crap. Sorry. Bull crap. Go ahead, finish it. Tell
If
them
there
why.
was only one hospital in the whole state, one cancer center in the whole state, then maybe. But those of you who don't know West Virginia geography, Morgantown's about 2 miles from the Pennsylvania border, and Pittsburgh is about an hour away. Guess what Pittsburgh has? A national level leading cancer center in the UPMC. So half the people in our population may drive the hour up there. So our whole data set, which was enormous, it was 2.3 million observations, still would not be able to answer that question. But they thought it would, because they assumed we were the population, and that's not true.
Immediately I thought you got selection bias.
Oh yeah, big time.
Massive selection bias, and that's the things you've got to worry about. So what I'm trying to say is, please, I'm not bashing the retrospective study. I actually think, and I've been proposing for almost 2 years now, should we not in the School of Public Health just offer a solid class on how to design well-designed electronic medical record studies? Period. If we're going to capitalize on this, it's there. It's not easy. We're trying to, everybody's acting like it's easy. It's easy to do it poorly. It's not easy to do it right. We want to do it right, so let's do it right.
And just to let you know, the stats and epi community are really interested in making sure that we have answers to those questions, so that if you come and have these EMR type questions, we can get there. There is a symposium at the end of this month. This is the 3rd symposium that University of Washington is running, that is all built on proper statistical and epidemiological methods for EMR analysis. And there's some excellent people who are all doing a lot of hard work so we can give you an answer. Because we want that data sitting over there. It's free.
It's free, yeah. You got access to it. All right? So, also always remember, though I did not emphasize, I think this is a reasonable place to start thinking about inclusion, exclusion criteria. Doesn't matter whether it's retrospective or prospective. Who should be in the study? Who should be in the study? Who are you going after? Why? Can you justify that for me? Because again, that's going to play into the budget, because we're going to eventually come back and say, we need this number of individuals. Can you get to that number of individuals? Okay, the other one that I reviewed in my role on the scientific review committee for UAB, looking at studies, before they're going into the IRB. And I had to stop the study. It was a retrospective chart review. Bottom line, they were going to study this rare disease that they estimated was 1 in 5,000 people. And they were proposing a chart review of 200 people. Do the math. They're not going to find anybody. And they had not thought that through. And you're going to say, how does that happen? They were rushing. When I got to them, I said, you do see what you've said here. And they said, okay, well, first, that's completely, we see why you're upset, but there are typos there. I said, okay, that's fine by me. Let's back up and discuss. But right now, you've got to be able to say, you've got a reasonable chance of, you're going to find 200 people. If you're going to go to 200 people, you need to ask yourself, how many people with this rare disease do you expect to find in the charts? What they had not clearly defined is that they had a specialty clinic that gave them access to 200 individuals that were known to have the condition. It was just a poorly written HSP. All right, going forward, cross-sectional or longitude. What do you think I mean by cross-sectional? In fact, bottom line is I could have just changed this to how many times are you going to touch the subjects? How many times are you going to record data off the subjects? And notice I did not say people. I did not say people. Because this could be an animal study also. You can have cross-sectional animal studies. You can have cross-sectional studies for individuals. But how many times will you measure the subject's outcomes and explanatory variables? One time. Will you just see them one time and get it one and done? There's limitations to what you can say in those situations. But if that answers your scientific question, that's fine. Just please don't use the word change anywhere in your application or in your study, because you're not going to measure change if you see somebody once and only once. You can have the standard pre-post design, or you can do the things that I do like in the VA. We see them at baseline, then we see them again at 6 weeks, then we see them again at 12 weeks. So it's a matter of questions. Dustin, what would you like to add?
So one thing to point out here is that if you collect data longitudinally, that does not mean that you have to use longitudinal statistical methods. For example, I'm working on a study where we have collected patient-reported outcomes on HIV patients, and they collected the data over a year period. We took their first one and got the exposure of interest, which happens to be marijuana use, and then we got the last one and got their level of pain severity. Well, I only had one outcome measured one time, but my exposure was measured previously, so I can look at change in pain severity as the outcome, but I look at baseline factors. So it is a longitudinal study, longitudinal data, but I'm analyzing it as if it was a cross-sectional study. Some people don't want to do that. You may have data enough that you can do something more sophisticated, and I highly recommend you doing something more sophisticated to make better pictures. But that doesn't mean that you have to do it. One big thing I want to point out, cross-sectional study. A lot of people don't want to do cross-sectional studies because they're trying to get at causation. It's not something we've mentioned here before, but a lot of people think causal inference, causal statements are sexy and what's appropriate. And that's true. That's true. They are appropriate when you can do them. And you can get at causal statements in cross-sectional studies. Longitudinal, much easier. Randomized trials, way easier. But that doesn't mean that you can't do it. But what it does mean, you have to do it the right way. And there are causal methods that you can use if that's what your question is. But if your question is not causal, then don't ask it. Don't bring up that you want this when that's not what you want.
Don't chase fads.
That's my dissertation. Be careful.
I'm not trying to insult you. I have people who come to me and say, I want to do a propensity score analysis. And I'm like, has nothing to do with your hypothesis. Why are you telling me this? Because they've heard it and they think it's popular and they've seen it in the journal.
It's sexy.
No, I like that term. And the bottom line is simply this, is that just to do that actually kind of shows how you don't realize how these 7 questions hang together. And I'm not trying to be critical, but it's just, I've always found it very interesting when people come to me and say, I want this analysis. It's not McDonald's, folks. It's not. And the reason to take the first 5 before the last 2, the first 5 are determining what I can do on 6 and 7. But I want to go back to and add an emphasis to one thing Dustin just said. By revealing how many measurements you are getting, you are allowing the methodologist to come to you and suggest, we can do it this way, or we can do it this way. Here's the pros and cons of the first analytic approach, and here's the pros and cons of the second analytic approach. Let's discuss this out to decide what do you believe is the best approach and would be most convincing to your colleagues. Because again, I'm not going to ever come up here and tell you there's only one way to analyze. That's not true. That's just, there's more than one way to analyze the data. However, by the time you've answered questions 1 through 5, you've narrowed it to a very distinct set of things that can be done. There's still some choices to be made, but it's not a whole landscape. You've narrowed it. All right? How many groups? Now, you'd think that, you know, sounds like a simple question, right? Not always a simple question. You got to stop and think, because often I've seen studies come in. Can we back up? I need to make one thing very clear. When we talk about like longitudinal, this happens a lot when I'm with study section. Okay, they'll think to themselves, okay, I'm going to do drug A, drug B, drug A and drug B. So I've got 2 drugs to compare, and I'm going to measure people at 6 months, 12 months, and 18 months. But it's the same individual over time. It's important you tell us when it's the same individual over time, because we will see in study section that fact is missed in the discussion in the design, and somebody's proposed a 2x3 factorial design, treating time as a factor. That's wrong. It's the wrong analysis approach, and it's just a sign that people did not have an in-depth conversation of how things were working. And there was a period, and this is, again, he's young, I'm not. 10 years ago, more than 10 years ago, 12, okay, let's see. I'm doing the math because I can remember.
You need an abacus?
No. It's probably, 16 years ago. I can tell you, 16 years ago. At study section, we had to triage probably 4 that day because the statisticians kept saying, wrong analysis. It looks on paper to be appropriate. That's a repeated measures. They proposed the wrong thing, triage. Just got to have those type of deals. All right,
So none of those got funded then?
None. None of them. Triage them.
Like I said, we cannot get your grant funded.
Well, we can
We
kill
can
it.
kill it.
We can kill it. And so to help us not kill it, talk to us. Okay, well, I'll tell you the other thing that'll kill you, going without it. And that won't work either.
Yeah.
That won't work either. No. So going back to this example, you need to count the number of interventions or treatments that you're using and dose level. I put the word dose level there because it helps people reason it out. Like behavioral intervention, usually you get it or you don't get it. But that's full dose, no dose, 0 or complete. And I've had a study where in the VA, we wanted to demonstrate and hopefully show that behavior, the combination of behavior and drug was better than behavior alone or drug alone. Okay? But as we were fleshing it out, the debate was, are we going to do, how many groups are we going to have? I would argue in that situation, and we got it funded, and we got it published, and everybody's very happy. I argue, you got 6 groups of things. I want a true control. A true control. Nobody, we're just going to observe you. After the observation period, we'll bring you. If you want to go on drug, if you want to be, whatever you want to do, but you're going to be true control. But that would give me 6 levels, so it's 2x3. And that's a 6-level, 6-group design. So just think about it. If you say, well, I've only got one thing. I've got one thing and I'm doing exercise therapy. Well, you're still going to probably have 2 groups. Okay?
Well, I would amend this question at the beginning to say, am I comparing groups? If so, how many? Because not every analysis, not every project are you comparing 2 groups of people to each other. One type of analysis could be that you're going to give your whole patient population or a subset of your patient population something, and you're just going to see what happens to them. So there's not really a comparison group, so to speak. And then there are the N of 1 trials, which I don't know if that's discussed ever in here. where it happens a lot in autism research, where there's no one child has a comparable child, and so you would actually treat the child with this treatment, wait a bit, and then treat them with the next, and so they compare against themselves. And it's actually 2 interventions. It's just all within the same child. You do it a bunch. It's called ABAB design.
Yeah.
But that would not have any groups. In fact, it has n equals 1. But you still would want to think through this about what was going on. So I would say, do I need groups? If so, how many?
Well, like I said, this is the first time we presented this, so we can revise this. Okay, going forward? All right, now once we get through all of that, this is where I make people cry. There's a word folded in there. This question tends to strike terror in people when I start saying, all right, you've got to tell me, to be able to estimate the sample size, you've got to be able to tell me what is a clinically relevant difference. If you're going to try to lower my blood pressure, if you're going to try to lower the blood pressure in the population, what's the minimum amount you got to drop it for it to be clinically relevant? It's a hard question. That's why you talk to your mentors. That's why you talk to your colleagues. Oftentimes, it is an opinion. People want to be able to say, I can find that in a book. You're not going to find that in the book. It's an opinion. Okay? Also, keep in mind, this is where we come up with statistical power. I've stopped using the word calculation. Yeah, it's a calculation, but it's an estimate. And I want you to all understand, anytime I do a power estimation for you, it's a weather forecast, folks. Okay, that's all it is. It's not a guarantee. It is, I'm telling the review group, if these conditions exist, this is a likely outcome, or this is a probable out. This is the probability of a specific outcome within the experiment. That's it. Okay. And I also get into the issue of this, and I'm interested to see how Dustin responds to my comment here. A lot of people will come and argue with me. Remember, it's fine. I like arguments. No problem. Not the first one we've had. And they'll say, I don't think we need a power estimate for that. You get that a lot of times with like microbiome studies. And my comment is, if you're putting a p-value there, or you're planning to report a p-value, you might want to have a discussion about power with somebody. Because anytime a p-value goes down, somebody should be asking, well, what was the power behind it? Do you agree or disagree?
Both. So, it is very rare cases in which you go into a hypothesis and a grant in which you will be doing a test and you won't need power. It is very small. But I'll give you an example in which you don't necessarily have to do power. I talked about it a minute ago about a pilot study.
I would agree with that.
So you have a pilot study, and what you want to do is have a very small amount of people in a control group, and then a little bit more people in your intervention group to get some estimates of things, because you eventually want to write the RO1. Right? And so a lot of people will then have a 5 to 10 sample control group. And at the end of the day, you're going to measure the difference between the control group and your intervention. And you might actually test it. You don't want to power that as a hypothesis test, because your power is going to be like 5%, 10%, because a well-powered study has a lot of sample size in it.
One step right back there.
So there you would want to do something different. What the current sexy thing to do is what's called precision estimates, where you talk about width of confidence intervals as opposed to p-values and power. But it is very rare. If you plan on doing a true statistical test, you would need to do some kind of power estimation. Now, it might not be the one that you want to do, and this is, Dr. Red was getting at this earlier. There are some times in which you propose an analysis that is new or very complex, to the point where power and sample size calculation is not simple. In fact, it might, I don't want to say it would be impossible, but it would be impossible in the time limits of your grant preparation. An example is mediation analysis. A lot of people want to do mediation analysis. I want to know how much effect is mediated by such and such. Well, there's one paper that goes through sample sizes for this under certain effects, but the amount of assumptions you have to make to get to that point is very large. So typically you would talk about that aim and you would talk about what would happen in certain scenarios. You don't actually get a power calculation. But I would say if that's your primary aim, you better do simulations. But if it's a secondary or tertiary aim, then that's okay.
That was the other thing. When you make the list of outcomes, and it wouldn't hurt at all to have a list of backing up or tertiary, would not hurt at all. And a lot of times I will help people just put down on a list of paper the things that they are planning to measure. And I will ask them, is that primary, is that secondary, is that tertiary? And make certain that you understand, not everything can be primary. Please understand that. Yes, ma'am?
What does clinically relevant effect really mean if you're someone like me who often uses large data sets of, like longitudinal data? I mean,
Oh, that is.
if I'm working with 20,000 people.
It should make no difference.
Yeah.
Thank you.
Yeah.
Okay, I was about to jump on that, but go ahead. You go ahead. Thank you.
If a 5-unit change in blood pressure, millimeters per mercury, is what's clinically meaningful, that if you can get somebody's systolic blood pressure down that amount, that is where you're going to have effects and improvement in all these things. That should be true whether you have 20,000 people or 200 people. Because it's the clinically meaningful, not the what can I find in my data set.
Right, you see, because the danger of what you do, and I like what you do, and I'm not being critical, the danger is, and this has been a thorn in my side throughout my whole career, is you will be extremely powered to find trivial, non-relevant differences. And people will run to publish that because they believe if it's statistically significant, it must be clinically relevant. False. That is a boldly false statement. It is not guaranteed that if it's statistically significant, it is clinically relevant.
Oh, I'm suspicious every time I get a significant result.
Good. Good. We have trained you well.
I'll give you an example from one of the studies. When I was a graduate student, I worked on a big HIV prevention trial from mothers to infants via breast milk. And they did a 2x3 factorial design, all this, that, and the other. And table 1 is we compared the 3 ART groups to each other across a bunch of measures they thought were important. And my advisor, my boss, said, let's run p-values because we want the p-values to be no different. Because you want to show that your randomized groups are not different. Well, it turns out, unfortunately, there was one p-value that was significantly different. Of course, I ran it on 10 things, so think about what that means. It was height. The women in one group were significantly taller than another group. But do you know what the average difference was? 0.5 centimeter.
So, I hope you got rejection over that, because clearly you're reading the number.
That was the point. The whole point was that when we saw a significant outcome and that worried us, but then when we looked at the actual effect, 0.5 centimeter, is that really going to make a difference in HIV transmission or any other? No. If there had been 2-4 centimeter difference, then maybe we could worry, especially since one of our arms was a nutrition arm. But no. So it didn't matter. Another example here, you all have heard about the REGARD study that is housed in our biostats department. Everything's significant regards.
Yeah.
Everything's significant regards. Because they had 30,000 people at baseline. So you really have to tease apart what is significant and what is important.
Right.
What is clinically important.
And I think, again, I use that, you are always going to be damaged by the people who trained you. And I think the phrase that he said, important, I was always told clinically relevant, but I think important is a better word. All right, last slide, so we can get y'all out of here and y'all can enjoy an extra 9 minutes. What should the analytic approach be? If you've answered questions 1 through 5, the answer to this question is predetermined in most cases. and has been restricted to notice I didn't say it's completely, it has been restricted down to a handful of options at this point. And we would need to discuss these things out. All right? It is important that everyone understands this fact. I have individuals who are great collaborators, highly funded NIH investigators, 30 years of experience that will not accept this fact. They will say, hey, why? Let's do repeated measures and others. And I'm like, it's not even repeated measures.
Never.
It's never. You don't have anything repeated. What are you talking about?
Never.
But they feel like they can just pull it out of the air. It doesn't come out of the air. It's restricted. It is equally important to know if you change any answer, question 1 through 5, change anything. And this is why I can't bring this study that is frustrating me to close. We meet every 2 days and one of the answers has changed. And so the previous meeting was just a waste of time. Yes?
One of the keys with this is I want to point out is that we don't have a monopoly on this or analytic plans. You don't have to have one of us or another methodologist write your analytic plan. You may be somebody who really likes statistics. Anybody in psychology? Anybody in psychology? Psychologists love to do their own statistics, and there are a lot of very good statisticians in psychology. Dan Meerman is over in psychology, and I think he can do a lot of my stuff better than I can. So we don't want you to do it, but what we don't want to have happen is you go and write your stuff in a vacuum. You think up what you think the analytic plan should be, and then later you get dinged on it for either in a paper or in your grant or something, when it would have taken a 5-minute conversation with us, and we might have been able to help you. Because I just want you to know that we're not trying to say you have to do all these things and you have to talk to one of us. That is not necessarily the case. But what it means is we want you to talk to us. We want you to do that. Sometimes we might not be able to help you. I mean, there's been times in which I've had to say to somebody, I don't know what to do to make this different. Because we're not infinite knowledge people. The person came to me with fMRI data.
Yeah, my trainer.
Good luck. But what we should be able to do is find somebody who can
help you do that. Again, I'm not asking you to use, I'm not saying that, as we said at the very beginning, I have argued many times with the upper administration, it's actually a healthy thing that there are methodologists staged around the campus, that there's just not, they're all sitting up there in Riles away from here, or they're all sitting up here in preventive medicine. No, they need to be scattered out. What I am asking you to do is to hold on to these questions. Use any methodologist you want, or and when I use that term broadly, I'm not saying that you've got to have a statistician or an epidemiologist, but you may have these, even if you have all this training and all the skill set to do the statistics, these 7 questions will help guide you and make it much more effective and efficient. The other thing I'm going to say in closing, never underestimate the value of graphs to show your aims and how your aims work together. Don't underestimate the usefulness of having, in meeting with someone, and to look at how they show a study design in a graph, how all these things work together. On the CCTS webpage, there's a library of funded grants for you to study to see how people have established their specific aims and gone through their study design. Okay?
What was